Hello everyone, my name is Brittany Smithley. I'm a Master's of Athletic Training student at Texas Lutheran University, and today I'm going to be walking y'all through a patient-centered, evidence-based evaluation of a rotator cuff tendinopathy. Rotator cuff tendinopathy is most commonly seen in overhead athletes and is referred to pain and weakness as a consequence of excessive load on the rotator cuff tissues with overhead activities. And the pathoetiology of rotator cuff tendinopathy is multifactorial and can be attributed to several extrinsic and intrinsic risk factors as they are laid out in your handout. The repetitive nature of overhead athletes' activities under extreme loading conditions at the limits of functional shoulder motion can lead to the development of chronic overuse injuries such as rotator cuff tendinopathy. So jumping right into taking a history, you not only want to inquire about any specific risk factors that they might have, but you also want to determine the nature of the pain that they're experiencing. So rotator cuff tendinopathy is a chronic issue. It's typically going to present with an insidious onset and may not only be hurting them during activity, but at rest afterwards as well. So if your patient has been experiencing pain for only a short period of time, or they can pinpoint a specific mechanism that caused their pain, this may change your diagnosis a little bit from a tendinopathy to maybe an acute strain or a different pathology altogether. And you can determine this information by asking them questions like, how long has your shoulder been hurting? Where is it hurting? Did you do anything that you think might have hurt it? Different things like that if it's progressively gotten worse over time. And rotator cuff tendinopathy is going to present as a dull, achy pain. It may be sharp with certain activities such as reaching overhead, lifting, getting dressed and undressed, reaching behind the back is a big one. And they can also complain of growing weakness with their shoulder pain or fatiguing quickly with activity. One big symptom that comes across with rotator cuff tendinopathy is going to be night pain. So this may present as a difficulty sleeping through the night. The pain might wake them up in the middle of the night. They might not be able to sleep on the affected side, or they might just be at rest. Their shoulder might be hurting while they're trying to fall asleep. That's a big indicator of rotator cuff tendinopathy as well. And to determine more specific activities of daily living that are giving them problems, you can give them a patient-reported outcome measure. A good one is the Disability of the Shoulder and Hand questionnaire, or the DASH questionnaire, and that'll just kind of help pinpoint, like I said, certain activities that are causing them pain. So some things you want to look for in terms of just some observations are going to be any abnormal humeral head translation to the anterior side. You're also going to want to look at her scapulas and see if there's any abnormal posturing or some scapular dyskinesia. You can have the patient kind of move their arms up all the way out in abduction, slowly come back down, and then you're going to go ahead and come back up one more time, nice and slow. And you want to make sure and see that her scapulohumeral rhythm is equal on both sides and that it looks quote unquote normal. Another thing that you're going to want to look for is if there's any swelling that might be apparent. And then when you begin palpating, you're going to want to touch on both the supraspinatus and infraspinatus fossa. You're going to want to palpate the greater tubercle, the lesser tubercle, and go ahead and get right in that intertubercular groove. You're also going to want to palpate a couple of other structures just to help rule some things out, such as the AC joint, Erb's point. And you're also going to want to palpate the muscle bellies of the trapezius as well as the rhomboids. So hopefully your patient's not point tender in all of these areas, but the areas that they are and are not tender can help you to rule in or rule out some of those pathologies. So people with rotator cuff tendinopathy are going to be most of the time point tender at their greater tubercle and lateral to that, so the proximal lateral area of the humerus. 70% of individuals with rotator cuff tendinopathy are going to have point tenderness in this area. If they have point tenderness for, say, in the intertubercular groove versus more lateral, that's going to be more indicative of maybe a biceps tendinopathy. If they have any pain at Erb's point, that's going to be more indicative of a neurovascular pathology. If they have pain over the AC joint, especially without mechanism, or if it's a more chronic situation that they're dealing with, that can be indicative of a more arthritic condition, such as distal clavicular osteolysis. And maybe your patient has no point tenderness at all, and this could be indicative of a more intra-articular pathology, such as a labrum tear or maybe an impingement syndrome. In terms of range of motion testing, your patient is likely going to experience a lot of trouble with flexion and abduction, and depending on severity, they may not be able to get past 90 degrees. With these motions, You're going to have them come all the way from the front up and come all the way down. And same thing at the sides, come all the way up. Good. And have them slowly come back down. Another thing that you can watch for bilaterally is if they have a drop sign or if they are unable to control their eccentric control back down. This could be indicative of a rotator cuff pathology. And then on strength testing, they're going to also have a lot of trouble with that flexion and abduction as well as external rotation. And from there we can move on to special testing. And the three best tests out there in terms of diagnostic accuracy and clinical relevance for rotator cuff tendinopathy are going to be Hornblower's test, external rotation lag sign or infraspinatus spring back test, and the empty can test. So for Hornblower's test, you're going to have your patient put their fist over their mouth as if they're blowing into a horn and have them abduct their shoulder to over 90 degrees if they can. And you're going to have them maintain this position for as long as they can, and a positive sign is going to be an inability to hold that position or quick fatigue or pain. You can go ahead and relax. For external rotation lag sign, I'm going to have her stand up for this one. External rotation lag sign, you want to have them abduct their shoulder to 90 degrees. Have them flex their elbow, and you're going to put them in a maximally externally rotated position. And then at this position, you're going to tell them to maintain that position and let go of their wrist. If they're unable to maintain this position, you will see their arm spring back when you let go of them. And whenever you do this, it's a positive sign for rotator cuff tendinopathy if they're unable to maintain that position. And then for empty can tests, we're going to have her internally rotate and abduct her shoulders, and you're going to put her in the scapular plane. You're going to apply a downward force and compare this bilaterally. A positive sign for this is going to be any pain or weakness compared bilaterally. You can go ahead and sit back down. So when we look at the diagnostic accuracy on these tests, the most sensitive and specific are going to be the Hornblower's test and the external rotation lag sign. While the empty can test is not as sensitive or specific, it is still clinically relevant in terms of testing the strength of the supraspinatus muscle specifically. And if we take all of these special tests and we combine all the positive signs we have, the more positive signs we get, the better our clinical decision is going to be, or the more confident. If you're not getting any positive signs with these tests, I would suggest doing some other testing such as Neer's impingement or Hawkins-Kennedy for subacromial impingement, or O'Brien's to test for a labrum tear. Throughout all of your clinical evaluations that you get from the history, observation, palpation, along with your special testing, you can use all this information and your clinical decision-making skills, as well as the common risk factors and findings that were listed in the literature. You can combine all of these to kind of help you direct your diagnosis, differential diagnosis list, and determine if you think your patient has a rotator cuff tendinopathy or a different pathology. And you can use this information to move forward with a treatment plan. And that concludes our patient-centered, evidence-based evaluation of a rotator cuff tendinopathy. Thank you for watching.